Many thanks for coming to our 6th International Conference of Pain Management in Goa.
So I start with internal oblique to look at the other structures. So here you can see the subcutaneous fat followed by the external oblique, internal oblique, and transversus abdominis. And then that's the abdominal wall with peritoneum seen there. So unless you know the anatomy, it might be difficult to say what these tissues are. But with the knowledge of anatomy, it's very easy then to say. Again, look at this. You've got anechoic artery. And why I'm saying that artery, it's circular. And when in real time you'll see this, you'll see that it's pulsating. Just to the lateral of this artery is the brachial plexus. And you can see, I said about the clavicle is the nerves are hypoechoic, but you can see here they are hyperechoic. Muscle, this is the medial scalene muscle just to the lateral aspect of the brachial plexus, and that particular tissue is not different from a vein. But because we know how the anatomy is, we can say that, and it merges with the hypoechoic areas, that's the muscle. And you can see the subcutaneous. This could be omohyoid muscle. So it's not always possible to be 100% sure. Right, so when you're scanning, to make sure that like you have the best of the image, you do some maneuvers with the probe to get the best view. And one of the maneuvers that is being suggested is goes with the mnemonic PART. And PART's P stands for pressure, A stands for really sliding, it's called alignment by some people, R for rotation, and T for tilt. So with changing the pressure, you can see the actual image sometimes becomes better or less better. Again, like if you want to differentiate veins from arteries, pressure will help you to do that. So with pressure, veins will disappear, artery usually doesn't, nerves don't. There are some hypoechoic nerves which might look like typical like an artery, but with pressure they'll never disappear. Sliding, you can do it on sort of like the lengthwise or widthwise of the transducer. And the idea is to see where you can get the best view. Again, like you can track the nerve along its length, and that way like you can identify which nerve it is. So if you have got confusion about something like median or ulnar nerve, you can see how it goes. Median will come towards the medial aspect of brachial artery, ulnar will go posteriorly under the medial epicondyle. As far as rotation and tilt is concerned, the idea is to cut through a structure in a perpendicular way. So the energy, sound energy that is transmitted and transmitted back is best seen in a perpendicular manner. So if you want to see a nerve, the best thing to do is try and keep your probe perpendicular to the nerve. You might have heard of the term anisotropy. So you, with a little bit of tilt, you can see the nerve. A slight bit of tilt might make the nerve disappear. So that sort of thing, cutting through rotation and tilt, you used to do that. So that's just depicted in images here. So pressure going in that sort of like axial direction, sliding, you can slide it either way along the length or along the breadth of the probe. Rotation is along one of the points along the length, and it need not be the center, it could be towards one of the ends. And tilt is on the edges of the probe. One thing that is not mentioned here is you can also put pressure along the heel or toe of the probe. And that way, like you can look at particular nerve which is in a different sort of like going in a different direction. Two other things you can play with the knobs on the machine are changing the depth and the gain. So with you usually start with depth a bit deeper than the structures you want to look at, so that like you're not missing any important structures. So if you're doing something like a supraclavicular fossa, you want to look at the pleura before coming out and seeing and focusing on the structures of importance. For something like supraclavicular, you'll start at 3.3 on this machine, and then maybe reduce it to focus the actual brachial plexus, as I showed you. Again, you can use gain to make sure the amplitude of the sound waves is right for you. So with gain, what happens is that all sound waves, both hypoechoic as well as hyperechoic the echoes, they are sort of like exaggerated. So you will see both becoming whiter if you increase the gain, and both becoming blacker if you reduce the gain. Whereas like in contrast to that, if you change the contrast, you will find that the black thing becomes more black, white things becomes more black, more white. So you can see the white against black in a better way. Now one more other important point to mention here is when you set the machine, make sure the machine is showing the right probe you want to use, high frequency or low frequency. Make sure it's on nerve rather than some other examination, like on that edge machine there, a different sort of like examining types or modes. There's 5 or 6 different, but nerve is one of them. Set it on nerve. And third thing is like you can change the frequency of even the high frequency probes. The frequency you have there is 6 to 13, but you can change it to have the lower or higher of 6 to 13. And what you do there is a knob which can change it from resolution to general to penetration. Yeah. So what you are doing by doing that is changing it from high frequency to low frequency. Remember, another thing is that these are very thin beams. Even though the transducer or probe might look about a centimeter thick, the actual ultrasound beam is paper thin. It's a fraction of a millimeter sometimes. And that's why we struggle sometimes to see the needle through and through in a in-plane technique. So in plane, out of plane, these terms you will hear all the time. And what it means is like your needle is in line with the length of the probe in plane technique, and in line with the breadth or width of the probe in out of plane technique. And in this image, you can get a visual impression of how the needle will look on an ultrasound image. When in plane, you can see the whole shaft of the needle, tip and the length of the needle, whereas in case of out of plane, you just see it as a dot. Beware that you're not seeing shaft and thinking it as a tip. Right? Another important to mention is with these high frequency probes, you're seeing the superficial structures better. So to do that, what you can do is instead of going very close to the probe, you have to start a little bit further away, as you see in these pictures. Now, I said about heel and toe. So one end of the length is the heel towards you, the other one is toe. And if you put pressure, what you do by doing that is reducing the angle between the needle and the probe. And also, if you see in the image, the other image, what has happened here, it's not cutting perpendicularly. It's oval in shape. And by doing that, what you have done is changed it to cut the structure of importance in a perpendicular manner. Ergonomics, we talk about this in ultrasound all the time. The idea is you do as little movement as possible. If you can set up your machine, your volunteer here or your subject, patient, and yourself in such a way that you just have to move your eyes and your hands, maybe your arm a little bit, but not your body and neck. Otherwise, like what will happen, you'll get neck pain and you'll have to go to Dr. after a few years. We will assume all throughout this masterclass that basics of regional anesthesia are followed. And what I mean by that is anytime you do regional anesthesia, you're making sure that patient is monitored properly.
has got proper IV access. There are resuscitation equipments in place. The sterility of the whole thing is maintained, and things like that. Another important thing to remember, local anesthetic toxicity is one of the common high morbidity type of complications. So, and it's very easy to avoid with ultrasound and with proper technique. So, okay, one of the things that is done in UK and in other places is what is called WHO check. I know some of the places do it here as well.
I go through making sure that I know which side the procedure is. I check it against the consent. I check it with the patient, that patient is fully aware that that procedure is being done on that particular side. In addition to that, I do a couple of other things. If it's upper limb block, it's very easy. I take sleeve out of the arm on that side. The other side remains covered. So even if after that I go on do general anesthetic or something, and there is a time elapsed between my initial check and my doing block, which sometimes is the reason why you do everything, check everything, and go and do the block on the wrong side. So what I do is then I place my machine in a position where my ergonomics is right, which means it is in a position where I can't do the other side. And one more thing I do sometimes, one thing that is forgotten is we can do the wrong block on the same side. We're talking about the wrong side block, but we can do something like a supraclavicular block when we wanted to do interscaling block. And to avoid that, I've got my arm positioned in such a way that I can definitely do, for example, if it's axillary, my arm will be abducted and flexed at elbow and things like that. One of the other thing people mention is mark the site, which we haven't been doing, but I'm very keen that marking the site in a separate sort of manner to surgeons would be a good idea. Any other question?
Have you got mic, please? Yeah.
Most of the hospitals which are JCI accredited in India, in this country, the site and the site both are marked.
Good.
So
I think that's an advance for UK and other countries which.
JCI, that's the JCI requirement. So
Yeah.
we are kind of moving towards it.
Do you have a particular requirements to mark that? Like some say it should be a circle and green.
So we have an arrow for the site.
Okay.
And we have a circle for the site. So site was occasionally you may miss the site because they will give me interscaling and suppose they have marked the site. So now suppose you're doing a shoulder surgery, they even mark. So you got to be really blind to miss both of them.
Sure.
And we have a WC surgery.
Yeah. One other thing I forgot to mention is they've tried to encourage stop before you block.
Yes.
Because in between the initial check and actually doing the block, you might be on autopilot.
Yes.
And you can do mistakes. So just before putting the needle in, just check again. That sort of thing. Okay? You've got.
To add what she's saying, what we do. Sometimes we do post-op blocks where patient come on propofol infusion. So the provider in the operating room will we have provided one small slips to state the name, age, everything, including what nerve block and which side. Because we do about 30-35 blocks. The block team can figure out, because in the trauma sometimes both limbs are on the dressing, so we don't know which limb is actually required. So we have this communication process where the OR team will officially write a slip and give it to the nurses. So we go through that slip and then we perform the work. So that's one way of also doing.
And who are you?
I'm Ramesh Ram. I am the associate professor in University of Washington, Seattle.
That's another problem, isn't it? If you have two teams looking after the same patient, I was talking about the same individual seeing the patient, deciding about the block and doing the block. But if two teams are there, it introduces another sort of phase where you can make mistakes. Okay, we'll crack on. I think we are already back on time. So Vipul is going to introduce the next speaker. And
Yeah, people, before you go further, so we've got two more people now. Professor Agarwal is here, who is the organizing chairperson. So thank you, Professor Agarwal, for coming. And Raj Kovinci is head at the Max Healthcare Delhi. So she's amongst you guys, Vipul, Raj and Prashant, to organize the show. So thank you, Raj. Thanks for coming.
Thank you so much. Many thanks, Prashant, for that such an informative initial lecture. So we'll just carry on with the program as we are planning to do. And our next speaker is Dr. Sanghavi. She works as a consultant anesthetist in University Hospital of Leicester. She's also program director for the MTA fellowships. And she had been doing regional for about more than 7 to 8 years now. I'll hand it over to Sunita now, please, for what she'll be doing is a masterclass on limbs, blocks above the clavicle. I present to you Sunita Sanghavi. Thank you.
Thank you. Good morning, everyone. So we're going to start off with the masterclass for upper limb blocks. I'm going to cover the blocks above the clavicle, and Prashant is going to cover the blocks below the clavicle. This diagram shows a quick representation of the parts of the brachial plexus that are blocked with the various approaches. So it's very crucial to have a sound knowledge about the anatomy to practice safely your regional anesthetics. The brachial plexus above the clavicle should be considered as a continuous structure. It is formed by 5 roots from C5 to T1. C5 and C6 unite to form the superior trunk, C7 continues as the middle trunk, and C8 and T1 they unite to form the inferior trunk. In the neck, these lie in the posterior triangle, and over here this is crossed by the inferior belly of omohyoid, the transverse cervical artery, external jugular vein, and the supraclavicular nerves. Now, as the brachial plexus travels further down, the trunks emerge along with the subclavian artery into the supraclavicular fossa, and they lie on the first rib. Underneath the clavicle, the trunks divide into anterior and posterior divisions. Each trunk will divide into anterior and posterior division. The 3 posterior divisions then unite to form the posterior cord. The upper 2 anterior divisions unite to form the lateral cord, and the lower one continues as the medial cord. In the axilla, all these cords will give off the terminal branches, which are musculocutaneous nerve, axillary, radial, median, and the ulnar nerves. So this is the tube map of the brachial plexus, which looks similar to our tube map of London Underground. But it's a very simpler form of the brachial plexus, easier to remember for the trainees. So a quick recap about the innervation of the upper limbs. We all know about this. Dermatomes of the upper limb. Now, there are 2 standard approaches to the brachial plexus above the clavicle, supraclavicular approach and the interscalene approach. So when you think about the conditions or surgeries below the shoulder, which cover the arm, the elbow, the forearm, supraclavicular approach is one that can do it all. Before the ultrasound guidance, only the brave at heart could try and use this approach because of the close proximity to the subclavian artery and the dome of the pleura. But with ultrasound guidance, this block is very desirable. It is safe, it is simple to perform, it's comfortable for the patient, and the block is very fast onset and complete in this area. This is because the trunks and the divisions are in close proximity and they are covered by a sheath. So now the block itself, the position of the patient is sat up or semi-sitting position. The head is turned on the contralateral side. You can either achieve this by moving the pillow away from the side to be blocked, or you can use a head ring. So now the next step is to the anatomy, so the landmarks. Identify the posterior triangle, which is formed by the posterior part of the sternocleidomastoid and the anterior part of the trapezius, and the base is formed by the clavicle. So you place a high-frequency linear probe at the base of the posterior triangle, just behind the clavicle at the midpoint. 100 millimeter stimiplex needle is used. You can either use a lateral to medial orientation of your probe, or you can use anteroposterior approach. Again, when I demonstrate this scanning on the volunteer, I'll tell you exactly what I mean. So this is the supraclavicular view of the brachial plexus. So you can see the the two scaleni muscle, the anterior and the middle scalene, and your brachial plexus along with the subclavian artery sandwiched in between. And they sit on the top of the first rib. So relating this to the sonoanatomy, over here you can see a linear hypoechoic structure, that one. That is the first rib. If you can't see this structure, then you may need to adjust the depth settings of your screen and then look for it again. The next structure to identify is the pleura, which can be seen on the other side of the rib. Again, it appears as a linear hyperechoic structure, and you can confirm the position of the pleura by asking the patient to take deep breaths, and it will cause a sliding motion of the pleura. Once you've located these two structures, then you look for a pulsatile structure sitting on the top of the first rib. This is your subclavian artery. Again, if you struggle to locate this structure, you can use the color Doppler and confirm the location of the subclavian artery. So after that, you can identify your brachial plexus, which lies almost superior to the subclavian artery with a posterolateral extension. And the brachial plexus in this area appears like a bunch of grape, a cluster of hypoechoic structures, which is this one. And here it is enclosed by a sheath. Just quickly want to show you an example of the ultrasound artifact. Now over here you can see this is the subclavian artery sitting on the first rib, and here you can see another artery. This is a typical double-barrel subclavian artery, but this is actually a reverberation effect, and you will see this when the ultrasound source is kept very close to a very hard structure, which causes the ultrasound energy to be reflected back to the source. So just keep that in mind. Just coming back to our brachial plexus view. So once you had a good picture of your brachial plexus, so this is the middle scalene muscle, subclavian artery, the anterior scalene is just somewhere there. You can see the first rib, the pleura, and the lung tissue just underneath them. This one here is your sheath, which is the extension of the prevertebral fascia. So once you're happy with the picture of the ultrasound image of your brachial plexus, then we think about the needling. So it can be either done in plane or out of plane approach. I prefer in plane approach, especially with the supraclavicular block, because of the close proximity of the subclavian artery and the dome of the pleura. So with the in plane approach, you can see the entire needle along with the tip, whereas with out of plane, it's very difficult to visualize your needle completely. The needle insertion point should be just at the posterior edge of your probe from there. So you can deposit your local anesthetic around the brachial plexus and you will get a block. But I think what is preferable is to enter the needle within the sheath and deposit your local anesthetic around the plexus inside the sheath to have a block. To ensure a good spread of local anesthetic, you may have to reposition your needle from various angles over there. Now don't forget this corner pocket which lies between the subclavian artery and the first rib. This is a common hiding place for the ulnar territory. It's also called as the 8 ball for the inferior trunk. Over here again you can see a good spread of your local anesthetic around the entire brachial plexus. Now what I would suggest is don't pre-decide the volume of the local anesthetic you're going to inject. Visualize the spread real time, and then once you've seen kind of a donut spread of your local anesthetic all around the plexus, you should get an adequate and successful block. But in my practice, I think 15 to 20 mL of local anesthetic is adequate to achieve a good block in the supraclavicular fossa. Right, so you've got to be cautious about the vessels which are going to be in your way when you're doing the brachial plexus block, supraclavicular approach. So this is your subclavian artery. It gives off the thyrocervical trunk, which is very close to the brachial plexus. In the branches of the thyrocervical trunk, which we all know, the transverse cervical artery, suprascapular artery, they can be also in your way. So always try and use a color Doppler, locate your vessels, and stay away from the trouble. You can also see the dorsal scapular artery sometimes, which is in the way. So complications, I'm not going to go through the general complications. We're all aware of the general complications with any peripheral nerve block. But the more important ones are to avoid the vessel puncture, intravascular injections, and all these vessels you need to be wary of. There is a significant incidence of pneumothorax with supraclavicular brachial plexus block because of the close proximity of the dome of the pleura. But again, with ultrasound guidance, the risk is reduced to a great extent. Now, before I go to the interscalene approach of the brachial plexus block, I just quickly want to mention about the continuous supraclavicular. This is indicated where you need a longer duration of analgesia or anesthesia. Now, it consists of 3 phases. One is the needle placement, which is your single shot injection. The second is the catheter placement, and the third is to secure your catheter. It is very crucial you stabilize your needle very carefully when you're inserting your catheter. You may be you're wanting to inject 2 or 3 mils of local anesthetic as you advance the catheter. It just makes it a little bit more easier. While withdrawing the needle, again, be careful not to dislodge the catheter. Once the catheter is in place, about 3 centimeters within the sheath, then you can secure it. You can either tape it or you can tunnel it. Tunneling is advised when you going to keep the catheter for a long time. So just moving on to interscalene approach. So this approach for the brachial plexus has been used for years. It targets the roots, mostly the upper root, C5, C6, and sometimes you can catch C7 as well. Again, all the several factors, the patient position, block at similar sort of position to the supraclavicular. So I have the patient semi-sat up, head turned on the other side. You can move the pillow out of the way, or you can use the head hang. Locate, again, the landmarks. So locate the posterior triangle, and then the brachial plexus in this area is sandwiched between the 2 scaleni muscles. So if you want to locate the landmarks, you need to locate the posterior part of the sternocleidomastoid, and the interscalene groove is just behind it. You can place the probe at the level of the cricoid cartilage in the interscalene groove and identify your structures. If you can't see the interscalene groove landmark technique, what you can do is you can start in the midline and then move the probe laterally, identifying the carotid artery, internal jugular veins, the 2 scaleni muscle, and the brachial plexus sandwiched in between. If you still struggle to locate your brachial plexus in the interscalene groove, what you can do is you can start in the supraclavicular fossa, as we discussed earlier, and track the plexus cranially. So this is the interscalene view of the brachial plexus. So you can see the 2 scaleni, the brachial plexus sandwiched in between, jugular, carotid, the posterior edge of the sternocleidomastoid over there. So how do we relate it to the sonoanatomy? Again, you can see the posterior edge of the sternocleidomastoid, middle scalene, anteroscalene muscle, the brachial plexus. These are the nerve roots here, and they appear as the hypoechoic structures stacked on the top of each other. The vertebral artery is not far away. Again, confirm the placement. You can use the Doppler to confirm the placement of vertebral artery, carotid artery, and internal jugular vein on this side. And this is the transverse process of one of the vertebra, cervical vertebra. Needling, again, in plane, out of plane. Again, the same principles. I prefer in plane approach because you can see the whole needle as you are doing the block. Make sure you have the local anesthetic spread all around the plexus on either side and in between the nerve roots. Right, now just dealing with some stragglers. So keep on the back of your mind that you might not always get the classic view of the brachial plexus as we saw earlier. So this over here is a hypoechoic structure on the anterior surface of the anteroscalene muscle. And these are the, you would think that this is the brachial plexus, C5, C6, C7, maybe, I'm not sure. But if you place a color Doppler, make sure this is not a vessel. And more than likely, this might be a C5 nerve root, which is passing on the anterior surface. Now, if you see this view, you don't really have to deal with this target separately, because the local anesthetic which you put in the interscalene groove will spill, and it will catch the C5 nerve root along with the phrenic nerve. The other variant you might see is that either the C5 or C6 nerve root is actually passing through the belly of anterior scalene muscle, and it will appear as a hypoechoic structure, a few millimeter in diameter. If you see that view, you have to deal with that target separately by putting your local anesthetic injection into the muscle substance and spread it around that. This is because the local anesthetic spill will not reach there, as the nerve root will be enclosed in the muscle sheath. So again, just to show you how the C6 nerve root is visualized, large, it's often split into two elements. So it's quite easy for for us to kind of confuse that it might be C7, but it's actually bifid C6 here. Again, if you concentrate on this picture here, so to find out where the C5 is, whether it's that or that or that, okay, it's quite confusing. And this hypoechoic structure is actually outside the fascial sheath. So if you put a color Doppler, you can see that this is actually a blood vessel. And either it could be either artery or a vein, depending on whether it's pulsatile or compressible. And this, your C5 nerve root, is actually that one. So again, the blood vessels above the clavicle, you've got to be wary of them and try and keep away from them. So the transverse cervical artery, suprascapular artery, again, these are branches of the thyrocervical trunk, which you should look out for and avoid them. So side effects with interscalene block, almost more than 100% incidence of phrenic nerve palsy with the interscalene approach. Horner's syndrome, because of the blockade of the stellate ganglion, and recurrent laryngeal nerve palsy can occur. Complications apart from nerve injury, although the incidence of pneumothorax is less, but you cannot rule that out, it can still happen. Intrathecal epidural injections and the vascular injections or injury, as we just discussed earlier. So just the highlights, scanning of the brachial plexus can be sometimes difficult. Interscalene approach, if you're struggling with the standard approaches, you can always start from the supraclavicular fossa, because it's very easy to locate the brachial plexus over there and then track it cranially. Avoid the vascular structures and other areas of trouble. Use Doppler wherever you have to, wherever you can. Never inject against high pressures, because that might indicate intravascular injection and cause neurological damage. Pros and cons of multiple injections. Now we spoke about the multiple injections, redirecting your needle to get a good spread of local anesthetic. So the pros are that you'll get a good blockade, effective blockade, fast onset, and you can actually reduce the total volume of local anesthetic you use. But you've got to bear in mind that if you are repositioning your needle, part of your brachial plexus will be anesthetized before you do the consecutive injections. So the risk of injury to the nerves is slightly higher. Needling approaches could be in plane, out of plane, and as I discussed earlier, I always prefer in plane approach. But there is a place for out of plane approach, especially where you have to insert the catheters. It can be more easier to use this approach. The needle trajectory is very, very important. The brachial plexus in the supraclavicular region and in the interscalene region is very superficial, about 1 to 3 millimeters at the centimeters at the most. So maintain a shallow trajectory of the needle to avoid interfering with the dome of the pleura, or if you're too deep, you can actually do an intrathecal injection or epidural injection with your with the interscalene approach. Try and avoid the phrenic nerve. I mean, you can't avoid the phrenic nerve blockade with the interscalene approach, but at least you can avoid damaging the phrenic nerve by. Now, how can you do this? So it's very, very important to identify the phrenic nerve. It crosses the anterior surface of the anterior scalene muscle from lateral to medial orientation, as you can see here. And this is how it will look on the scan. So this is your middle scalene, anterior scalene, your brachial plexus just there, and your phrenic nerve is seen as a hypoechoic structure. If you scan up and down the neck, you will see this hypoechoic structure sliding up and down the anterior surface of the scalene muscle. The other structures you can see here is the posterior edge of the sternocleidomastoid, and you can actually see the superficial cervical plexus here as well. it's very easy to block that. So depositing local anesthetic just deeper to the sternocleidomastoid underneath the fascia. This is the fascia. And this is the superficial cervical plexus. So how can you minimize the phrenic nerve blockage? So know your anatomy. Approach the brachial plexus at a lower level if you can. Obviously, that will depend on the indications why you're using it for. To reduce the incidence of motor blockage, you can use smaller volumes of local anesthetic, lower concentration, and you can use ropivacaine, which causes more sensory than motor blockage. Thank you. So, So I'm just going to demonstrate the supraclavicular and the interscalene brachial plexus block on the wall.
All right, so when Sunita is setting up the probe and machine, any questions so far? Yeah.
Not in big patients, why do you need a 10 centimeter needle?
Yeah, that's because of the.
I use 5 centimeters.
Yeah, that's perfectly all right. You can use 5 centimeters, you can use 15 centimeters, okay? Yeah, but then we use 10 centimeters because normally when many times patients are obese, so it gives you, so you don't have to change the needle again. So it's more from cost point of view that you're not swapping the needle. So you can always waste that one because price is same of 50 and 100. So that's
unless
all.
it is obese patient,
Yeah. And then sometimes what happens that there is abnormal normal variance of anatomical variance, and then you need to move your needle around, so that helps. So that's why. Ideally 5 centimeters needle, very good point, Nikhil. Ideally 5 centimeters needle is all right. Yeah. Any more questions? Yes, please. I think it is a good idea to introduce yourself as well because everyone is senior faculty here, and then that's how we'll know each other, okay, throughout the day.
I come from Christian Medical College, Vellore, and my question to you, ma'am, is what steps you take to make sure that you are not depositing drug intraneurally?
So again, after monitoring the pressure, I could never inject against high pressures, and it is recommended that it shouldn't exceed more than 50 psi.
You can do it precisely. If you want to avoid intraneural injection, you can avoid it precisely. What you do is think of this as a nerve, okay, and this as a needle, right? A needle is going in near the nerve. Now we are not in a radiology suite. We don't have too much of time. Our machines are not great machines as well, okay? So if skin is somewhere there and needle hub is here, so when needle goes near the nerve, before depositing local anesthetics, if I move my hub around, if needle glides over the nerve, then it is outside. If it drags the nerve with it, then your needle has punctured it. Okay, simple glide sign. Always do it. Even the smallest of the nerve, you can see that. You just move your hub outside once you approach the nerve, and then if your needle is gliding over the nerve, that means it is outside. A. B. You can have some appreciation of eyeball assessment of the nerve size. So the minute you see that that nerve size is increasing, don't ask the injector who is injecting the solution to stop, because then there's a thinking time and a stopping time. The best thing is just move your needle away, okay? And then you can again introduce it, because we are using ultrasound, so we can reposition our needle. Yes, tell him to stop, but then at the same time, just withdraw your needle so that your needle comes outside the nerve, okay? So, yeah, Rajan. Ravinder,
from All India Institute. We can use nerve stimulator also. There are also needles are there. You have 2 ports, one for using nerve stimulator and one for injecting the drug or saline. So yeah, you can use, if you are more precise, you can use it. You can use nerve stimulator also. Yeah. If it is still coming the fasciculation or coming in spite of below 0.5 milliampere, then you think that you are inside the nerve.
Yeah, it's very good. It's very good. It's very good. But then there's a personal experience as well, all right? Yeah. So it depends. It depends. So say for example, I want to demonstrate something to a trainee, or a new trainee is doing a block. I always give option to the patient. Basically, probably, I should not say I
Left
cheat
is
with them,
2.7.
but then I give them options. And then I
We
pick
just
up the
left
option which is suitable to me. Okay, so I give them, in England, you have to ask patient because you need to explain everything. You know, you need to tell them that what's the incidence of injuries and things like that. So I always give them option. So if patient says, no, I want awake block, no, and then very anxious, then I don't encourage trainee to do that block then. Then I do it myself. Because in my personal experience, I have found that if you do awake block, it is more convenient because patient is supporting you. You know, that you can reposition patient and the block is quicker and then you are more safe as well. Okay, so yeah, whenever you are ready.
Yeah, one of the ways to avoid phrenic nerve block is to stay posterior and deposit local anesthetic posterior. You may avoid, phrenic nerve.
Yeah, I'll show just Sunita. We are just discussing. We have got whole day to play, so don't worry. Yeah, there are ways and means. So now what happens that in my person, everyone has got own experience. All of you are very senior faculty. So in my experience, I've seen that scalene muscle are like 3 slips, 3 or 4 slips. So they are together, but then they are like these 3 fingers there, okay? And then there are weak junctions there between these slips. So normally, what I have seen is that local anesthetics doesn't go over the anterior muscle
At 25
and
minutes.
then go to bathe the phrenic nerve. It can go through these slips as well. So even when you deposit about 5 mils, 8 mils, or 10 mils of local anesthetics, then also many times you see local anesthetics bathing the phrenic nerve. All right. So it's very important that to avoid it in a way, but then it is also very important that after putting in a block, you are doing again a scan to just see whether local anesthetic is sitting there or not. Vipul, you want to add or you should?
I was just adding to you, sorry. My name is Vipul. I'm working in UK in University Hospital of Leicester's. Adding to your question, how can you avoid any neural damage? I'm not promoting any companies. However, B. Braun has come up with a device. If it's attached distal to the syringe of your injected port, if it hits certain kind of pressure, you can physically see that it'll become red. I see one person who's nodding her head. That's correct. It's a very small, yeah, it's a very small kind of thing, but I think it's about for £3. And at the moment, which NHS, everything is very expensive. We're cutting down on cost. However, I was lucky that the rep gave me a few devices, and it works really nicely. And another thing is, if your patient is awake, it's a small little thing where it increases the pressure that just pops up. You know, like your pressure bags. You know, when you have to inject fluid in the pressure bag, there's a small little device which tells you if you hit the 300 mark or you're becoming from green to red. It's a very similar to if you're putting more pressure. So I think it's about 10 psi, that if you're going ahead more than that, then it just shoots up. And also bear in mind, how many ml your syringe is. Because with a smaller syringe, pressure is, inversely proportional to the area. So smaller syringe, you can generate higher pressure. So be careful of that. And plus, if your patient is awake, if it's within the nerve, they'll experience severe pain. Not always, but they may. Same like as my colleague, when he was talking about nerve stimulator, there might be a subcategory of patients where you may be inside the nerve and you may still not see any twitches. Right? Thank you.
Sunita, thank you. Jyotsna is also professor at AIIMS. Okay, yeah.
Yeah, I have one more question. We have been hearing about grape of bunch for a very long time. Do you try to identify what grapes are they?
Yeah, this is Ekta. You are making me very, very happy. I'm moving away from signature pattern to dynamic imaging, and we are working on a book as well about that. Now, ultrasound is no more signature patterns, okay? But then for easy understanding, we use those words and terminology so that larger audience can understand. But then basically, we track them. So we do dynamic imaging, and then you track the brachial plexus or whatever structure you are interested in, because now we should act as a radiologist as well. You should know what are these structures. So thank you for coming and joining us here.
So my question, I'm Sujit, working at SGPG IMS Lucknow. My question was somewhat similar to hers, that can we visualize C7 in interscalene, or how can we differentiate C5, C6, and C7?
I think, Sujit, I think, Sujit, you are holding very important position, and you have worked with Professor Anil Agarwal at Sanjay Gandhi Institute of Medical Sciences, which is like very finest center I have come across. I think you should go through seriously through few of the well-known faculties here, how ultrasound image looks like, what you can do. Because I think that ultrasound is better than MRI scanners or CT scans for chronic pain people. And that's why we try to bring in all kinds of machines. Not only Sonosite, you will be having a GE machines as well. And there's Philips, Toshiba, and other machines. So you should know which is the best of the machines, because specifications matters a lot, and then they produce images better than MRI. Okay, and then you get soft tissue images as well. In X-rays, you don't get soft tissue image. So yeah, I'll show you one block. Yeah, I'll show you one block for shoulder that is Nook block as well when we explain to you how I do it session. Okay, so yeah, carry on, Sunita.
Okay. So we just start scanning now. We'll start with the supraclavicular approach. So again, ergonomics and everything Prashant has discussed and told you about. So ideally, I would be standing at the top end with my target here in the middle, and my ultrasound machine will be on this side. Okay, at the base of the posterior triangle. And you can see the hyperechoic structure, the linear hyperechoic structure, which is the first rib. So again, if you direct your ultrasound beam slightly caudate, you get a better picture where your subclavian artery is just sat on the top of the first rib, your brachial plexus is superior with the posterolateral extension. Thank you very much. Okay. So you can see this linear hyperechoic structure, which is the first rib. This is the subclavian artery pulsating round anechoic structure, and your brachial plexus is just that one enclosed in a sheath, superior and posterolateral extension of that. Now, if I just slide this probe, just minute movements of my probe, again, slightly caudate direction, the pleura moves quite on the other side, and the artery is lying on the first rib. If I do it the other way around, you can see that the artery is now on the pleura. And you don't want to be in that position to do your block. So you want to angulate your probe so that the artery lies on the first rib. Okay, take a deep breath, please. Okay. So now when the patient takes deep breath, you can see the sliding motion of this pleura, which is that one. Okay, and you can locate your visceral pleura there. From the lateral aspect, okay, and you deposit, make sure you deposit the local anesthetic in this corner pocket as well to cover your ulnar territory. And I usually reposition the needle again to make sure that I've got enough spread of local anesthetic within the sheath at the top and laterally. So this is one way you can place the probe. The other approach is the anterior-posterior approach, which in UK sometimes is also called as the Darby approach, where you put the probe just by the root of the neck. So if you lie the patient on the lateral side and place a pen, where it rests is where you need to place the probe. Okay. So this is the view with the anterolateral approach. And this is quite useful if you have a patient who has got a very deep supraclavicular fossa as well. So again, identify your first rib, subclavian artery, and your brachial plexus is just superolateral to it. Okay. So I'm just going to move on to the interscalene approach. So the various scanning methods which I spoke to you about before was you could start in the supraclavicular fossa. You can start in the supraclavicular fossa and then track it cranially. So just keep your eyes focused on this nerve bundle. Okay, sorry. Okay. So as you scan up in the interscalene groove, you can see the two scalenii muscles there. Sorry. So there we go. Okay. So your anterior scalene muscle, your middle scalene. Okay.
Middle scalene, yeah.
Yeah. Middle scalene, anterior scalene, and your brachial plexus is sandwiched in between the two scalenii muscles. Okay. So you can the goal is to identify the plexus as proximal as you can to achieve the interscalene brachial plexus block. So that is your brachial plexus. You can see the C5, you can see the bifid C6 over there, and possibly underneath it is your C6. Now, the vertebral artery is very close to C7, and yeah, in that region. So I also want to show you the transverse process of the cervical vertebra. If you can increase the depth.
Increase.
Oh, sorry. Okay.
That is.
So there you go. Okay, so there's transverse process of one of the cervical vertebrae there. Okay. So again, in-plane approach to the brachial plexus. You can come at the top of the C5 nerve root underneath the fascia and inject your local anesthetic over there. Make sure you've got enough spread on both sides of your plexus. And sometimes, you can inject local anesthetic in between the nerve roots as well. But again, you've got to be careful not to do intravascular injection in this area. I usually do the patients, the blocks awake, and as we discussed earlier, so do not inject if you encounter high pressures. If your patient's awake and if you're intraneural, they're going to have severe pain, and they will not let you inject into the nerve bundle. Any questions so far with the scanning? So it's just the probe placement is, the normal classical one is this, okay? Yeah. Over there, and the Darby approach is where, so if you have your patient on the lateral side, you place a pen just there at the root of the neck, and that's where is the probe placement. So this is how it will be. There we go. And I think the needle comes from the posterior aspect, just the anterior border of the trapezius muscle here, and I feel it's a little bit more safer because you're far away from the dome of the pleura with this approach. Rather than lateral approach, you're quite close. Okay.
This is Info Media Prime Slot Network, and you're watching Prime. Your voice, your channel.